morning. This is a recording of a presentation I recently gave at the Beatrice Nicoletti and CHOP Resuscitation Science Center conference on pediatric resuscitation. My talk was to talk about sustained inflation and other novel techniques, and given the time constraints of this talk, I will mainly focus on sustained inflation during chest compression. What do we know? In newborn infants as well as in pediatric patients, high quality chest compression are the cornerstone to achieve ROSC, or return of spontaneous circulation. We have taught everyone to press hard and fast with minimal interruptions, particularly in pediatric resuscitation, while in neonatal resuscitation we interrupt after every third compression to provide ventilation, because ventilation in neonatal patients is often regarded more important. Regardless, pressing hard and fast with minimizing unnecessary interruptions has been shown to achieve ROSC faster. When we have asphyxia, and that's again regardless of being a newborn infant at birth or any pediatric patients or infants down the line, adding ventilation further improves the time to ROSC as well as neurological outcomes 24 hours later, if you compare this to just giving chest compression. This highlights the importance of ventilation. A pitfall of chest compression is de-recruitment, which occurs with each chest compression. And this rather nice study from anesthetists, where they gently pushed down the thorax and then released it, and the mean force they applied was like 160 grams per kilo patient weight, which is gentle push compared to the massive force and hard compression doing chest compression. So when they push down really gentle, they found that in many of these cases, from a newborn baby onwards to a 17-year-old, the lung is de-recruiting and air getting pushed out of the lung is higher than the dead space, and the dead space here is highlighted with this big black line. So when you even just gently push on a chest, you de-recruit the lung. Now, how is this in neonatal? How is this doing chest compression? Well, an adult study showed 7 minutes of chest compression without ventilation increases the atelectasis from 25% at starting point, measured with a CT, to 75% after the 7 minutes. So a continuous de-recruitment of the lung. In neonatal and pediatric piglets, what we found is that per 3-to-1 cycle, you can lose up to 4.1 mils per kilo. And in pediatric piglets, for each of this cycle, you can lose up to 6 mil per cycle. So you lose a lot of volume doing this compression. Okay, as I said, with 3-to-1 or CCAV, so continuous compression with asynchronized ventilation like it is done after intubation in pediatric advanced life support, you de-recruit the lung. Our group used a different approach where we provided a high descending pressure of 30 centimeters of water, which we call sustained inflation, and then provided continuous chest compression. You can see this here. With the T-piece, you occlude the PEEP valve to provide the high distending pressure, and then you continuously do chest compression at least 90 per minute. What does it do? If you look at the flow waves, if you look at the top one, the gas flow, every time you push the chest, air comes out, but during chest recall, air goes back into the lung. So you continuously pushing the air out, which you do with all chest compression technique, but now you're passively aerating the lung, you're passively ventilating because doing chest recall, air flies back into the lung. Now in our first animal study we did in newborn piglets, we realized that with this technique compared to the standard approach, we roughly had a 75% faster time to ROSC and a significant higher survival as well. So overall, significant higher survival and significant shorter time to ROSC. Similar when we did this in pediatric piglets. We had significant faster time to ROSC with the CCSI technique. And also a significant higher amount of survival. You can see it was like 12 versus 6. So twice as much as well. And this continues in all of our studies, that we find that there is significant faster time to ROSC and higher rate of ROSC or survival with this technique. When you analyze the ventilation, you can see that CCSI recruits the lung. So you get an increase in volume as you provide chest compression. Now, over many years, we have done many animal studies and found that in all of them, time to ROSC was 75% quicker. Mortality often half. The pulmonary artery blood flow was twice as high. The pulmonary artery pressure was twice as high. We had a higher carotid blood flow, so more blood also going to the brain. A lot of people are worried about this sustained inflation causing problems with venous return. We never had any differences in venous return or venous pressures, that there were higher to basically support that there was an impaired venous return, which was higher compared to 3:1. We had significant higher minute ventilation, therefore resulting in improved alveolar oxygenation delivery. We achieved, as I said before and showed you, passive ventilation, and never an increase in lung or brain injury or any markers of pneumothoraces. And you can see that here on the right side, no difference in the inflammatory markers, and the right top shows you that a pressure, the standing pressure of at least 25 centimeters of water is needed to get a volume of around 5 mils per kilo into the lung. And based on all this animal research, we started our Survive journey, where we try to identify if CCSI compared to 3:1 will improve outcomes for newborn babies. The initial study we did was a feasibility trial in less than 32 weeks gestation, and we found a similar improvement in time to ROSC, where it was around 75% quicker. On the left bottom, you can see that there is a recruitment of tidal volume compared to a de-recruitment with 3:1. Now these babies were all less than 32 weeks, and many of them were around 25 or 24 weeks, and there were a couple of babies within the CCSI group which have passed away. So certainly something we have noticed and need to continue to monitor. Now, based on this, in piglets, 3:1, we have tidal volume loss. In humans, we have tidal volume loss. CCSI tidal volume gain, newborns tidal volume gain. This led us to the second trial, which was a cluster randomized multi-center pilot trial, where we tried to get 218 infants, 104 infants per group, to detect a 33% reduction in time to ROSC. And we included all preterm babies, and the hospitals were randomized to CCSI or 3-to-1. Unfortunately, due to COVID in particular, we were unable to complete the trial and had to prematurely stop the trial. We were only able to recruit 11 babies in the CCSI and 14 babies in the 3-to-1 group. Here you can see the time to ROSC, which is around 90% faster, 90 seconds with CCSI versus 615 seconds or over 10 minutes with 3-to-1. The p-value is 0.016 because this was a cluster trial and didn't show any significant differences. As I said, we had 11 and 14. You can see that the survival was twice as high with CCSI, but our survival with 3-to-1 was 50% lower than the general survival from the database, as you can see. And so therefore, it is rather challenging to know if this increase is actually true and needs further studies. Here is the summary of both of these trials, where you can see a mean difference and reduction in time to ROSC by roughly 2 minutes, or in this case 115 seconds, and mortality showed no difference. This leads us to our current clinical trial, where any interested site is welcome to email me to join this trial. This is now SURVIVE-2, which was funded by the Canadian Institute for Health Research. Our primary outcome this time will be mortality until NICU discharge. Secondary outcomes will include time to ROSC and every parameter described in the neonatal Utsting. Our sample size is 554 infants with 277 per group, which then could reflect a number needed to treat of 8. All infants born 28 weeks or older, cryo chest compression in the delivery room will be included, and hospitals are randomized for at least 12 months and up to 24 months into one chest compression approach before they switch to the other chest compression approach. I would like to acknowledge everyone who has worked over the last 12 to 13 years on this approach. And if you want to get in touch with us to be part of SURVIVE-2, please email us, and I'm now happy to answer any questions. Thank you.